Hello, and welcome to my presentation on urban and rural differences in healthcare costs. Approximately 20% of the U.S. population resides in a rural area. That equates to about 60 million people, 25% of whom are older adults, and that population is growing rapidly. Health centers are funded by the Health Resources and Service Administration, provide much of the clinical care in rural areas. Rural populations tend to be more socioeconomically vulnerable than urban areas, and more older adults live in rural areas and utilize nursing homes compared to urban areas. 44% of the HRSA-funded health centers served rural populations in 2017. There are previously documented disparities between rural and urban healthcare, such as rural health centers being generally understaffed. 85% of rural U.S. counties are considered primary healthcare professional shortage areas, which signifies a lack of access to care, a lack of quality care, and understaffed health centers usually mean overcrowded health centers, which usually disincentivize utilizing the health centers, so the services are underutilized. Rural populations tend to be higher in older adults. The patients in rural areas tend to be older, female, low income, uninsured, obese, and in poor health. Aging populations require additional medical care in the form of nursing homes and assisted living facilities. For this research project, I sourced data from the California Department of Healthcare Services. The dataset provides characteristics of California hospitals for fiscal year 2019 and 2020. This data does not include psychiatric hospitals or alcohol and drug rehabilitation facilities. The variables that I selected include rural, non-rural, and rural remote characterization, the cost to charge ratio, and provider base rates. The cost to charge ratio is a ratio of cost divided by number of services or number of charges, and the provider base rates is wage adjusted income levels for providers across the state of California. In these two graphs, the same data is being displayed. The California hospital cost to charge ratio by rural, meaning yes, or non-rural, meaning no, classification. In the chart on the left, the cost to charge ratio is shown in a stacked bar graph. The number of non-rural or no classified hospitals is 353 hospitals. So totaling each one of those hospitals together, we have stacked each individual data point on top of the next. And for the yes classification, or meaning rural classification, there are 62 hospitals. What is significant here is that the data for the yes rural hospitals generally is higher than that of the cost to charge ratio for the non-rural classified hospitals. So when I say the ratio is higher, what I mean is each individual stacked bar is thicker or contains a higher ratio within each bar. So even though the overall non-rural classified hospitals bar is taller, its individual stacked bars are a lower cost to charge ratio overall. And to help show that data more clearly, I've also used a histogram box plot on the right side. So the no non-rural classified hospitals has a lower cost to charge ratio average than the yes rural classified hospitals. Similarly, the data in these two charts are the same. The data this time is California hospital statewide base rate by rural, yes, or non-rural, no classification. Again, on the left, I utilized a stacked bar graph to show the overall sum of base rate per provider for the no non-rural classified hospitals. Again, that's 353 hospitals with a grand total between $2.8 and $3 million overall. The yes rural classified hospitals have 62 hospitals with a total of about $1 million in provider base rates. To show the average of each hospital, we used a ring chart on the right. So the non-rural, no classified hospitals have a lower base rate average between $8,000 and $10,000, whereas the rural or yes rural classified hospitals have a higher base rate, averaging the most data points existing between $16,000 and $20,000. So out of 353 non-rural hospitals and 62 rural hospitals, the overall ratio is 5 to 7 to 1 non-rural to rural hospitals. So if we had an equal cost to charge ratio, we would expect a 5.7 to 1 non-rural to rural ratio for the cost to charge data. However, we see the ratio is actually 3 to 1 non-rural to rural, meaning that the rural hospitals are costing more, charging more per service. Again, for base rates for providers, if we were expecting an even distribution, we would expect a 5.7 to 1 non-rural to rural ratio in base rate for providers. However, we see a 2 to 1 non-rural to rural ratio, meaning that for every rural dollar spent for base rate providers, for the base rate wage for providers, only twice that is spent in non-rural hospitals rather than 5.7 times that rural base rate. That means the cost of charges is lower in non-rural hospitals and the base rates for providers are lower in non-rural hospitals. We need more data to discern why this variation exists. So we could find ways to provide services, fees, and billing procedures to improve the charges and base rate imbalances between non-rural and rural hospitals. I would suggest conducting data collection to discern the most utilized services, the fees associated with those services, the billing procedures associated with the fees and services, and the wages for providers. We need to adjust hospital fees and provider wages to make the imbalances less pronounced, especially since rural areas are usually have populations more socioeconomically vulnerable. So having a higher cost to charge ratio is a social disparity for those populations. Alternatively, we could improve access to care in rural areas that would reduce the financial impact of underutilized services, especially in preventive health care. We could also offer additional incentives outside of income incentives for providers to work in rural areas. Thank you for attending my presentation today. Have a good day. Thank you.